All right. Hi, everyone. Thank you for joining in today for the Policy Round Series webinar. We'll just give it a moment for folks to join in, and then we'll begin shortly. So hi, everyone, and welcome to today's Policy Round Series webinar with Dr. Carole Estabrooks, professor at the Faculty of Nursing, University of Alberta. So the Policy Round series were created to enhance knowledge translation of aging and technology research through policy-oriented briefing presentation. Each webinar in this series will last 30 minutes, beginning with this short introduction I'm giving right now, followed by a 15-minute presentation from our guest speaker and a 10-minute question period. The presentations in this series will focus on the policy implications of research findings. Speakers will discuss the challenges that their research aims to address, what their findings are, and what all of this means for future decision making. So now I'll pass it over to Dr. Carole Estabrooks. You can go ahead, Carole.
I need you to unshare before I can share. Yeah, there.
Yeah, I got it.
Let's see what we can do here. Great. Hopefully everybody can see that. So thanks for the invitation. I'm really pleased to be here. I'm going to talk a little bit today, very little. It's a pretty short presentation about the workforce and long-term care and about mental health and well-being generally. And I'll do that by a few opening comments, and then I'll present a brief overview of an intervention we did in the middle of COVID to try and help people manage some immediate stressors that they were dealing with. Before I start, we often think of mental health as an individual issue, problem, thing. And it is. Many of us come to our workplaces with our own histories and challenges around mental health. But I might argue
Carole, I can see your notes right now. You want to share the slide, first slide?
Can you not see my slide?
Oh, I do see the slides, but I also see the ones coming after. Is that okay?
Yeah, it doesn't matter.
All right, all right.
Give them a preview. So I want to go back here to this. I want to talk about the importance of the work environment, and I want to talk about how mental health and well-being and quality of work life and job satisfaction, all those sorts of things that we're looking at quite intensely now, are heavily influenced by the work environment, and talk a little bit about how powerful structural influences are in affecting the well-being of workers. So I don't want anybody to go away thinking mental health is an individual problem only, and because it's really easy to slip into a blame the victim thing. We did an individual intervention, but nonetheless, it's influenced heavily by the work environment. And in fact, some of the homes that we were in, you could see how they could take it in a positive way and create positive work environment features and structural influences. So we measure work environment or context a lot over the last 17 years. And we have a measure that we use to do that. and it's made up of things like leadership and teamwork and culture and resources and communication and engagement in work activities and a number of other things. Consistently, we find that staff reports of physical and mental health are better in what we call the green or the more favorable work environments or work context. Consistently, over 17 years now, we have these data. We also find that care processes are better in green or more favorable environments. This slide is about miscare. This is a problem across the globe in all health settings. This is about long-term care homes in Canada. And so even if you don't do anything else, if you're in a green home or a more favorable work environment, you will miss less care and you'll also rush less care. That has implications for interventions and strategies and initiatives that focus on the work environment rather than the individual only. Like, you know, for example, with pain, we often say, well, we got to do education and the pain staff should know how to do that, blah, blah, blah. But that's only one small piece of the puzzle. The work environment is a really major influence on how we work and how we live if you're a resident in long-term care. Moving from work environment now, I just want to give you an example of what we saw before the pandemic and then in the middle of the pandemic with burnout. We use the Maslach burnout inventory. We've used it for a long time. It's been used for decades. It's really well validated. This slide is pre-COVID and, well, it says post-COVID. It's actually mid-COVID. The bottom three bars are managers, nurses, and care aides before COVID, right before COVID. And the top three bars are of the same manager, nurse, and care aide groups in 2021. So you can see what was happening. Emotional exhaustion is the most sensitive of the three scales. That's why I've chosen just to report it. The others follow a very similar pattern. The managers in particular moved quite dramatically in the wrong direction, if you will. So the red bars mean the percentage of people who would be at high risk for burnout. So green's good here and red's not so good. The managers went from about 20% at high risk for burnout to, they doubled it to over 40%. We saw this in other things we looked at in managers, and this is especially important because this is the most stubborn, stable measure you can imagine. It just doesn't change easily. So the fact that it moved that much is really, one should sit up and take note. The nurses also had quite an increase, not as much. And the care aides didn't report the same increases on this particular burnout set of burnout scales. They certainly took a significant hit. They cope differently, they are different, and that points, and this doesn't mean they're not experiencing the same challenges the others are, but they're managing it differently. Part of that is because they're working in teams, and where they have stronger teams, they're managing better. And that's pretty consistent with what you would hear if you spent any time in the trauma literature. It's about coping, and in part is about connections and being with people. And that's certainly what a good team's about. So now let me talk about the breathing study. It's a technology, if you will. I thought I better use that word because it was aged well. It was funded by Healthcare Excellence Canada. This was done in 2021 in the middle of COVID. It's not an RCT. We did what we could with the resources we had and all the homes having outbreaks. So we did a pre-post study. It's a strong pre-post, but it's still a pre-post study. It does not have a control group. But the results are such that I have quite a bit of faith in it. This is the intervention. Breathing's not like a radical thing. It's not like a new thing. Every mental health professional, I would imagine, worth their salt, uses breathing to help ground their clients and to help calm them down. There are zillions of variations. Yogis use breathing. People who teach Pilates use breathing. A lot of people, well, we breathe naturally, but a lot of people use deliberate breathing strategies for various reasons. This is one variation that there was at least a tiny bit of evidence about. Most of these things have no evidence, but there's a lot of experiential understanding that they work. So we taught people to breathe into a count of 4, 5, or 6, whatever they could manage, even in and out breaths, and breathing low into their belly, so slow and low. And we taught them asked them to start with 1 to 2 minutes a day and work up to 8 to 10 minutes a day, more if they wanted, for 5 to 7 days per week. And we considered 5 days a week to be adherence to the little protocol that we had. They kept diaries so that we could track this breathing, and we did some other things to track it. If you like pictures better, this is the design. It's a pre-post with 8 weeks of coherent breathing, a little bit of reminder work in the middle, but not much. We started them with some measurement, and then we did a really short little teaching session on how stress affects your body and why breathing might help it. And then we did some post work, and all through that, they breathed. That's the big thing they did during that. And we did process evaluations. We looked at their diaries, we sent them little surveys, and then toward the end, we started doing focus groups, a lot of focus groups. There were 2 groups. One group just breathed, and the other group, we had the clever idea that if we used a biofeedback device like the HeartMath thing, you clip on your ear and you can get visual feedback on whether your breathing's reaching a state of coherence. We thought that group would do better. They didn't. They did about the same as the regular breathing group, which was good because just plain breathing is cheaper and easier to do. And the study ran, as you can see, from February to the fall of 2022. We started with 356 people from 30 homes. It was a convenient sample. This is who they were, and 254 completed the whole thing with all the post measures so that we could do our statistical modeling. We measured stress, anxiety, depression, resilience, insomnia, and the ProQoL-9, which has the compassion, fatigue, satisfaction measures in it. Those were our outcomes. And then we adjusted, for those of you interested in this, on these sorts of things that might also influence the outcome. After we ran the adjusted models, adjusted for age and sex and language and ethnicity and role, how much housework they did in a day, we were trying to look at things that might either be burdensome or supportive, their shift, the hours in a week, what kind of things they were doing for coping, and what kind of habits they had around substances. This is the result, if you like tables. Everything except compassion, satisfaction improved, some of them quite significantly from pre to post. We don't think that the improvement in COVID was a cause because the thing only ran 8 weeks. So it's quite a short period of time. We were pretty pleased and excited about this. We expected some improvement, but not quite as much as we got, for example, in insomnia. That's the Insomnia Severity Index, and in depression and anxiety. Please, I'd appreciate it if you don't take photos of that, because we've just resubmitted it after making revisions. So we're waiting for the journal to accept it, we hope. The process evaluations that we did really supported the numerical findings. We did, as I said, questionnaires and focus groups and breathing diaries. And the summary of what they told us in the focus groups was that they felt it had improved their sleep, they felt more relaxed, less stress and anxiety, they felt better physically, and that used it in multiple situations. We didn't ask them to, but once they hit about 5 weeks, it took about 5 weeks for them to build the habit and start to feel the effects. And once they hit 5 weeks, they started doing all kinds of interesting things with their new tool. It's really a tool. For example, during work, before work, after I got home, before I went to bed, anything at work, if it was anything that happened or anything with some of the residents, I use breathing just to back up and take 5. Another one said she didn't expect to have such a good improvement just from breathing. The fact that your stress levels will go down and you'll be able to focus more on what you need to do. After 5 weeks, this is the stuff that started to happen. I work with a lot of residents that have advanced dementia, so they can't communicate. But when you're calm, they're calm. So I try and calm myself down, and it helps them. This is something I thought we would have had to teach or do another study for, or something. They figured out themselves that the residents could co-regulate with them. That's what this is about. We all co-regulate with our partners, with our children, with animals. And if the person or animal you're co-regulating with is calm, it helps you be calm. and vice versa. So they figured this out and they started using it, which was really exciting with residents. And this is a manager who really went to town in her home. They're having breathing huddles. They do it after they have an adverse event, just to get everybody's levels down. They start their debriefs with a breathing session. This is pretty exciting home. We're going to go in and do some videotaping there and get some, real live from the people who actually work their stories as we build a little toolkit to disseminate this with. Not everybody did that, but there were some instances of that. And we want to do the video to show what is possible if you really get on board with it. I could talk lots more. I could talk about trauma-informed care and how it's not just about residents, it's also about the workforce being healthy and having stability and a good quality of life. But I'm going to stop because this is a super short webinar and just take questions and comments. Thank you very much for listening. I appreciate your patience. I'm going to stop sharing too, just so that I can see what's going on here.
Thank you so much, Carole. For everyone, please feel free to type your questions in the Q&A.
People can't talk, right? They have to type them in the Q&A?
Yeah, they have to type in the Q&A.
I like it better when we can talk, but I know in large groups we use the Q&A.
Yeah.
Yeah, the toolkit, sure, I can talk a little bit just about, I don't know what stage we're at. We're going to have it finished early in the new year. I do know the end date. We're taking, we want to make, all we're going to do is make a landing page, and I'm hoping HEC will host it. And on the landing page, you'll land there and you'll hit a start icon and it'll open up a little 2-minute video. This is what we think is going to happen. This is what we did. This is what it does. And this is what you can find here. And then there'll be 1 or 2 short 2 to 3-minute videos, a couple of infographics with an emphasis on either walking you through it if you want to read it or taking you through it if you want to breathe to something. We'll put the published papers and some lay summaries with them. And that's all we're going to do because we want it to be simple. We want people to land. And then if they only want to look at one thing, to go to the one that they can learn how to breathe. And we'll put information in it. We'll really put some emphasis on it doesn't work until you build the habit. And that takes about 5 weeks. So if you can hang in that long, it'll work. I hope that answered the question. So that'll be publicly available, hoping on HEC's website in the new year. Here's a person who used it at work. Excellent, great. Organizational factors. Teamwork's one of the most important. The kind of culture on your unit, and that's a mishmash of things. The kind of immediate supervision you have, that's what leadership is for us. The amount of engagement the care aides in particular have. And what's really, we do a bunch of other things, resources, how much resources you have. How much care aides, I think I said this one, are engaged in decision-making around residents. And that's pretty low in all homes. And that can be improved. And importantly, part of how we assess environment are the care aides' perceptions of whether they have sufficient staff, time, and space. And those don't always match what you actually have. And it looks like the perception that you have adequate resources is at least as important as what you have. And that's probably a function of teamwork and your local unit culture. Those are all modifiable. Some of them harder than others to modify. We were really interested in not big executive leadership. That's important too. But who do you report to most often, like your charge person? So the care aides report to RNs and LPNs. The nurses tend to report to the care manager. And the care manager tends to report to somebody up the chain a little bit.
All right, we are not getting any more questions at this time, but I find that the breathing exercises are very important to keep people calm. Is there a way for residents to do the same thing along with with the support workers, for example?
That's a really good question. Absolutely, if the residents got enough cognitive capacity to follow directions and to do it with you, probably with reminders, because about 80% of people in nursing homes have dementia. It's not always diagnosed. It's often, we'll see that in the cognitive performance scores, but increasingly homes have moderate to severe levels of dementia. And how do you get them to breathe this way? Well, you just aren't going to, right? What we think might work, and I've got a doctoral student trying to test this out, is if you do something that's calming, like a live therapy animal, and we don't know the dose and frequency yet, that the resident will get an improvement in heart rate variability. We can't measure their subjective feelings, but we can put a little clip on their ear and we can watch their heart rate variability, which is a outcome of breathing like this. We could also deliberately train staff and ask them to deliberately pause before they go in the room and do some measures. So you can't do it directly. I think it's going to be about co-regulation. It's not just about co-regulation, but if you're talking about breathing, because it's really all about sympathetic and parasympathetic nervous system. We're trying to crank the sympathetic fight and flight down and raise the calming parasympathetic system up so that you get the release of the good hormones and the relaxation. So there are ways. It's just that's a real big interest of mine, is how do we translate this? And what we thought was the first step would be, if the staff aren't calm, the resident's not going to be calm. And this doesn't happen at a mental level, it happens at a physiological level. If anybody here is a parent, you know what it's like to soothe the child. Well, that's a form of co-regulation. They're co-regulating off your nervous system. It's really kind of fascinating, actually. So there's ways we can work with residents. We just have to put our heads to it and think about how we can do that.
Talking of which, for older adults and caregivers, I've just added a link for any support you might need, or if you want to work with Age Well, there's a link in the charts. Thank you so much, Dr. Estabrooks. I think today we are going to have an early finish. I don't see any other questions in the Q&A. Yeah. So if there's any other questions, please feel free to reach out. I'm just going to grab her email address and just pop it into the chat for those who want to reach out. Sorry, that took me a moment, but feel free to reach out to Dr. Estabrooks. I've just added her email to the chat. Thank you so much. I will reach out to you through email for us to get the PDF presentation, and feel free to exclude any information which is not yet available.
All right, great. Thank you again.
Right. Thank you so much. Bye.
Goodbye.
Bye.